microenvironment of the hair follicle, the energy and nutrition are also involved. In the treatment, we only have 2 treatments approved by the FDA, finasteride and topical and minoxidil, not oral. The rate of response for treatment is different in many patients. From terminal to miniaturized hair and eventually the follicular loss is what we aim to stop and reverse. But patients respond very well, and some others do not respond very well, and others do not respond at all. And how soon it can start? Adrenarche starts at 6 to 9 years with the adrenal secretion of DHEA, and after this, the peripheral conversion of testosterone to DHT could start this phenomenon if genetic susceptibility exists. And then the hair follicle will shorten and the miniaturization will be progressive. So androgenetic alopecia could start as early as this year. And then, in the other hand, we have older patients after menopause, and we can have also androgenetic alopecia as a trigger after these androgen-secreting tumors. This is a case that we saw and published many years ago, and the treatment here is the tumor excision, and then we can use topical minoxidil. So the impact in quality of life could be very important, and this is a condition, AGA, could be so distressful. And patients could start with self-induced behaviors as trichotillomania. We've seen patients with pattern trichotillomania that has also androgenetic alopecia. So this could be distressful. So the last weekend I visited the Prado Museum. This is the museum that I love the most in the world. And I took the chance and saw Antinous. And Antinous is a symbol of a Greek culture where hair is a symbol of youth, strength, vitality, and health. So inspired by this, I intentionally asked the artificial intelligence to develop a model progression of how his alopecia might have progressed. And this is what we got. So in my personal point of view, androgenetic alopecia should be treated as early as possible in life, before Hamilton Norwood 2 and before adolescence ends if it started too soon. And this is the expert consensus from Spain. Here we have, according to the experts, the standard doses with anti-androgens and minoxidil for male patients as a first-line therapy and second-line therapy. And here we have the same information, but for female patients. Again, the first-line therapy with anti-androgens and topical and oral minoxidil, and a second-line treatment too. So androgens reduce the DHT levels in the scalp by inhibiting the 5A reductase enzymes, and dutasteride is the most potent, and it reduces DHT in the scalp by over 90%, but we have also androgen receptors agonists that may help in androgenetic alopecia. Topical finasteride has become very, very common, alone or in combination with topical minoxidil, and the evidence supports the benefit of this drug in a topical way. It could be a solution in percentage that ranges from 0.1 to 0.25, and also we have a gel presentation of 1%. And again, combination with topical minoxidil could be synergistic. And what about intralesional anti-androgens? We know that they may be effective. This is a report from my colleague David, who is here. And mesotherapy with dutasteride, they propose sessions every 3 months according to the long half-life, which is different from previous reports. And the current evidence supports the potential treatment options in traditional way with bicalutamide, botulinum toxin, and minoxidil. This is the way I do this in my practice. I always use dutasteride, 0.01, and in some patients, I add bicalutamide. I started with 4 treatments in the first year, then I spaced them out in the second and third year. Side effects in anti-androgens are important, is a concern. Here we have standard doses for finasteride and dutasteride, but also we have side effects. The most important side effects are sexual dysfunction, and we have now a concern about mental health. Post-finasteride syndrome is still controversial. The center of the debate are sexual dysfunction and the mental dysfunction too. And the EMA had a warning recently because the increasing cases of suicidality. And here we have this question. Is there a possible genetic link between 5-alpha reductase inhibition and depression? So the reason behind this is because an increasing reports of this. So the physiopathology behind this is that the inhibition of 5A reductase can reduce also some neurosteroids in the brain, as allopregnanolone. When we reduce this type of neurosteroids, we also will reduce the modulation of some excitatory neurotransmissions like GABA receptors. When we have this, we have a potential contribution to mood instability and suicidal ideation. So this is only for predisposed patients. So one tool that we can use in the practice is this type of tool like HATS questionnaire that may help identifying this type of patients. So let's move on to minoxidil. We know that it prolongs the anagen phase and shortens the telogen phase. And the way you do is that through the vasodilation and also an anti-inflammatory and beta-catenin signaling, and also it's presumed an androgen effect. So these are the side effects of oral minoxidil. Here we have the standard doses and the most important side effects. And the most important side effects are hypertrichosis and the cardiovascular symptoms. Here we have a report from Latin America. We have now this e-poster presenting here, so please visit and you can read more about it. And what we knew from this report is that previously reports have shown hypertrichosis in 50 to 40%, and we identified, according to the questionnaires to the patients, in up to 77%, mostly in face and extremities as shoulders. So please visit this poster. So oral minoxidil could be also safe in some heart diseases, but we should be careful with some patients with heart failure, and it's not recommended for them. And we also be careful when patients have more than 3 drugs for hypertension. So what about higher doses of oral minoxidil? We can use them in some patients that are not responding with lower doses, but again, we should consider that all the side effects are dose dependent. This is an ongoing study that we are doing in our city. We are comparing different doses of oral minoxidil, 1 milligram, 2.5, 5 milligrams compared with oral dutasteride. And we are doing some cardiologic tests, and we are still working on data, analyzing the ambulatory blood pressure monitoring, the cardio ankle vascular index, and flow-mediated dilatation. So we hope to present these results soon. And what about emergent treatments? These are the current recommendation for PRP. We're going to discuss that with our friend Daniel in the afternoon. So please be there. And the recommendation is 3 monthly sessions and use only 2 to 4 milliliters volume per session, and then subsequently space them out every 3 to 6 months. The activation of PRP is no longer recommended. And what about light-based therapies as low-level light therapy and some drug delivery techniques as MMP, fractional radiofrequency, and some other lasers as erbium? They are effective. And this is new. This is a new wavelength laser, which is at 675 nanometers, and targets the collagen. This is a new target for lasers, and collagen is important because it's part of the microenvironment for the hair follicle, so this is a new perspective to stimulate and treat androgenetic alopecia. And this is an example from my practice. This is a young male with 10 sessions only, is monotherapy, and we confirm with 10 sessions of this laser that we can reduce vellus hairs and increase thickness. And what about exosomes that are becoming very popular? And we assume the importance in the hair because it has regenerative properties that we assume that could be helpful for the hair follicle too. The problem with this is that they are not approved in most of the countries. And what about hair transplantation? We have international expert consensus that recommends to prepare and post-treatment after the hair transplantation. And they recommend to have AGA stable, have enough follicles, and do not perform in young patients or patients without treatment. So we believe that we dermatologists must be part of the process, and hair transplantation should be part of the plan when we initiate treatment for androgenetic alopecia. We must discuss this and avoid to the patients enter in the black market of hair transplantation. And what about a special population as children, pregnancy, breast cancer, and trans community? The androgenetic alopecia in adolescents can show a different pattern comparing with adults. This is an example of 3 different young boys that has this MAGA-F pattern, which is a male androgenetic alopecia with a female pattern, which is more common in this population, up to 50% compared with 20% or less in adults. But most importantly is the comorbidities, because acne, insulin resistance, vitamin D deficiency, and polycystic ovarian syndrome are also important, and we should diagnose and treat. And this is an algorithm that we published this year in this book, focused on trichology in pediatric population. We have this algorithm that shows the treatment for female and male patients, starting with topical minoxidil 2 to 5%, then add oral minoxidil in lower doses compared with adults. In women, we use 0.25 to 0.5, and in male patients, we use 1 to 2.5 milligrams per day. We also can use topical finasteride or spironolactone, and we can add also finasteride, but we need to adjust the dose. This is the only case that I've seen with gynecomastia with the use of anti-androgens. It was a boy, a young boy that he started androgenic alopecia at 15 years old, and he developed gynecomastia after 6 months initiating treatment with finasteride. So the reason I show this is because we must be careful with this type of population, because young patients could be even more sensitive for adverse effects. And this is the current recommendation. This is brand new for breast cancer, not only survivor patients, but only at-risk patients. And green boxes are safe. We can use topical or oral minoxidil and also spironolactone as a first-line treatment. And yellow boxes need more information. So what about trans community patients? This is the first line treatments for masculine and transfeminine patients, topical minoxidil, oral finasteride, and low-level light therapy. And for transfeminine patients, we can use oral spironolactone and as a first-line treatment. But always treating this type of population is challenging. And what about new controversies as GLP-1 receptor agonists? We have two theories here. In one hand, we have the theory that this type of drugs can stimulate the hair follicle by stimulating the sensitivity for insulin and then stimulate the blood flow, so it's positive. But then we have this phenomenon with weight loss and hair loss, and we have the second theory where these type of drugs can be disrupting for the hair follicle. And this is exactly what they saw in this report, and they identified that some of these GLP-1 drugs, as semaglutide and tirzepatide, could be disrupting for hair follicle because they saw the association with the onset or worsening of hair loss. So be careful with these new drugs because they have been so popular. And what about breaking news? New targets that become controversial and very common and very known in the web, and we have this type of viral phenomenons. This is because they propose this as a new hair miracle because it's a new target. We have this type of drugs that targets the mitochondrial carriers. This is new. The preliminary reports support the idea that this type of targets could be helpful for androgenetic alopecia, but this is preliminary. We still need more data. So thank you. This is my take-home message, and you may take a picture of this. This is the summary of this information about treatment for AGA in adolescents, adult life, elderly, and some specific population as trans community patients, breast cancer, pregnancy, and lactation. And as a take-home message, combination therapy is the best. Anti-androgens are essential, but we need more data, specifically in adverse effects as mental health. And oral minoxidil and topical minoxidil is a must, but we should discuss hypertrichosis with our patients. And the strategy here is to have an increasing doses plan. Then for future perspectives, we must see some targets that are in the environment around the follicle, and as the mitochondria, some other cells as fibroblasts and the collagen. And management for AGA should be started as early as possible, and we always should remember that it is not just hair. This type of conditions should be so distressful for some patients. So, mi casa es su casa. On va boire beaucoup de tequila. See you in Guadalajara, my city, in 2027. See you there for the World Congress of Dermatology. And this is the wonderful people with whom I work. And thank you, Dr. Rudnicka, for being a mentor and such an inspiration. And thank you all for your attention.